So my topic today is going to be looking at emerging perspectives in soft tissue augmentation. Obviously for us, over the years, being able to document, photograph, really analyze, look at the results over time. And certainly for me, I've done that with Henry and David and Ronnie, and now Abtine and many, many others who are part of our extended family. Then being able to share that information. David mentioned sharing of that information. We do it through the Dental XP website, through the forum. We'll be working on a brand new launch of a new website, hopefully in the end of this year, to really include and involve as many people as possible in what we call crowdsourced learning, crowdsourced sharing of information. So I certainly welcome you to come to the site at www.dentalxp.com, not only look at the content, but also share your own cases, interact with others on the Dental XP forum. We have so many beautiful and talented dentists from all over the world willing to share this information with you and with us. And as David mentioned, especially with techniques changing so rapidly, it's really important to have these key figures, these key people who are willing to share this information in real time. And today it takes so many years for publication to finally get accepted and posted that by the time it does, sometimes it's already 2 or 3 years old by the time it gets in your hands. So what are we here to really resolve? The problems that basically present to ourselves on a daily basis. And this is a perfect example of such a case. A patient with a history of implant placement, augmentation, bone augmentation, who over time, over years, has developed obviously a soft tissue deformity, an aesthetic dislike of her restorations, an implant that was placed quite a long time ago, a maxillary left central incisor, discoloration, recession, that has caused a disharmony of the gingival margins, a disharmony in the lip frame, as David has mentioned so many years ago in his 10 Steps to Smile design that he used to do, and really was the concepts behind lip-generated procedures that we do today, where we involve multiple facets. Now, I'm going to be talking to you, obviously, at some point in my presentation about some of the new techniques. We say minimally invasive as opposed to microsurgical. Some of them are microsurgical, some of them are minimally invasive. But in many procedures, we have to decide when it's necessary. So when we're looking at designing a treatment plan for such a patient, we have to consider where we're going to make our flaps. What is the location of bone around the implant, around the adjacent teeth, the interproximal bone levels. So before we ever consider the procedure of choice, whether it's going to be a tunnel technique, a vista technique, or any of the other myriad sources of techniques, we have to decide what in fact are we going to need to do to take care of the disharmony in this patient's situation. Does the implant need to be removed and replaced? How many times have we had to make that decision? So we take a look at this through cone beam CT evaluation, being able to detect whether or not there is in fact enough bone to maintain that implant on the labial, interproximal, and palatal aspects in 3D. We go ahead and we learn from each other. This is actually a technique I learned, believe it or not, through Dental XP. Dennis Tarnow and Stephen Chu were presenting on managing complications around implants, and Dennis suggested that before we do anything, we remove the abutment and the crown, and we allow for the soft tissue to grow over the top of the cover screw, allowing us a little bit extra soft tissue to work with when we actually do our definitive surgical entry. So here you can see this just after a few weeks, the soft tissue has grown over. It's still a collapsed ridge, there's still discoloration, you can see the metal of the implant, but yet we still have more tissue than we did when we first started, and we now can look at this site and decide what kind of flap to use. Is it going to be a tunnel? Should we be afraid of the interproximal bone levels? How are we going to manage this situation, and how are we going to be able to rectify the disharmony in the gingiva? If you take a look at this, this is certainly far from a microsurgical, minimally invasive technique. This is tried and true, full thickness, and then partial thickness dissection. And why did we decide on such a flap design? Really depends on the interproximal bone support around these teeth. That we had enough bone around the implant to retain it. And now we can go ahead and utilize two different approaches, two different types of tissue. One from the tuberosity, one from the palate. The palatal tissue aimed more for labial augmentation, root coverage, and the tuberosity tissue aimed at rebuilding the thickness and height of the implant site. And being able to do this in techniques that have been talked about for many years, using PTFE sutures, we use marionette sutures, and we're able to locate the graft from the tuberosity over the implant site and the soft tissue graft to take care of the recession on the adjacent abutment teeth. The sutures are removed at 2 weeks. Crown lengthening was also performed at the same time to gain some balance and symmetry to the gingiva. So we are combining procedures: crown lengthening, soft tissue augmentation, ridge augmentation, and reburying the implant, which so often is necessary in order to gain a superior result than what the patient presented with. The question remains, can we still use the implant? Is it in the right location? An impression should have been taken at the time of surgery so that our laboratory technician can see whether or not this is an acceptable situation for recovering this implant. Decisions that we have to make based on implant location, angulation, the ability for us to construct an abutment that's properly contoured subgingivally to support that soft tissue. We then get another chance, a second chance, to further augment that through second stage procedures. Now, this may be considered minimally invasive. Bendable microblades, something that many of you saw last year. Marcus Herzl presented at this symposium in Florida. Being able to take that tissue, deepithelialize it, and then roll it forward to gain even more tissue for that implant site. The abutment, new abutment is placed. It's then contoured correctly to support the tissue, and then we can start the process of seeding a new temporary restoration. Having the thickness of tissue now in the area on the labial, at least 2 to 3 millimeters to hide the metal underneath, gaining the symmetry in terms of the gingival margins, something that didn't happen early on. And you can see that now the restorative dentist can utilize the soft tissue that we constructed at the midline to shape the tissue and the level of this tissue through manipulation of the emergence profile. So this is something that obviously we can do for this lady, taking an old restoration with disharmony, aesthetic deficiencies, and being able to turn it around in color, shape, and harmony of the soft tissues. So when we think about current trends in gingival grafting, I think all of us have to consider the fact that we're still using a myriad of old techniques, then also adding onto them some of the newer techniques. We still want to consider lateral pedicle grafts, connective tissue grafts of all kinds, which is still the most commonly used. And then today we have different variations of coronally advanced flap techniques, whether it's tunnel, vista, semilunar. We've certainly heard of new ones over the last several years. And then when and should we use acellular dermal tissue? How does it compare to autogenous tissue? And I think if we can do that over the next several minutes that I have with you, then that certainly would be what I want to achieve. Let's first talk about how things have moved very rapidly in this arena. This is a patient I treated with David about 20 years ago. We did a hip augmentation. She was in a car accident. We did bone augmentation, replaced 7 of her teeth with implants in the maxillary anterior region. And unfortunately, over time, she started to get recession. There was a lack of attached gingiva in this area. And we augmented this area then about 13 years ago with free gingival grafts, vestibuloplasties, free gingival grafts. And this is 8 years later now, almost 20 years since we treated this patient. Thick, free gingival tissue aimed at maintenance, protection of the implants, and sometimes we get a little lucky and we may even get a little bit of creeping attachment as we release the muscles. So it's something that I think we often don't recognize is it's not just about the bone, it is also about constructing tissue for maintenance of the bone around the implants and long-term preservation of the cases. This is now a 20-year-old case. If we think about some of the new techniques aimed at this area, Tomorrow we will have the opportunity of seeing Istvan present his work, but this is a technique that he spoke about and published on last year in IJPRD, where he talked about using just small strips of autogenous free tissue to get vestibuloplasty, and then on top of that using mucograft to gain volume of keratinized gingiva. We also have the ability to use some of the new bioengineering concepts. It's really a delight for all of us to have Joseph Chakroun. He's going to be presenting some of his wonderful ideas related to bioengineering, growth factors, and certainly look forward to that presentation later on. But we all are also moving in a direction of bioengineering that is also recombinant in form and in a really remarkable situation, being able to use living cell cultures for grafting, and that's really the future. Here's a patient that I treated. I was part of a pilot group utilizing these living cultured sheets, and these sheets were really unique. They were used in burn victims, diabetic ulcer patients, and this was a product called Gentuit. It was allogenic cultured keratinocytes and fibroblasts in a bovine collagen. And this was really a medical device that was used for medical patients. And then a few years back, it was approved, and FDA approved, for the utilization of free gingival augmentation. We would take these cultured living tissues, living, not dead, and we would then transplant them. We'd create the same bed preparation and avoid a donor site. And this was incredible technology that we were able to utilize, and it was quite interesting to us, being able to graft not with dead tissue, but actually with living cells. We had the upper layer of keratinocytes, the lower layer of fibroblasts. These were all living tissues, and we were able to utilize it. And this first study that was done back in the Journal of Perio in 2008 by McGuire was a proof of principle that this could work. Copac was placed. We can see how we sutured to gain vestibular depth, and this was early wound healing. And if you look at that, that looks very similar to what it would look like if it was autogenous tissue. And here you can see 3 months, and this is now several months away. New keratinized attached gingiva using living cultured cells. How exciting was this when we looked at this over time and compared the pre-op with just thin mucosal tissues, and then at 6 months having this type of tissue complex. This was the study that was published, the pilot study, really back in 2008. Amazing. It's called Applegraft. It's sold as a medical device today. The dental division no longer sells the material because they closed it due to lack of sales to keep that division open, but the product is still available. And this is the cases that Dr. McGuire presented as a baseline, comparing free gingival grafts, autogenous tissue, to living cultured cells, and then taking this and comparing it over time to the results over 6 months and then over a year. His conclusions were that the material was safe and effective and provided significant benefits for patients in the treatment of mucogingival conditions. Here's such a patient that I treated in our office with Henry and David. It was an immediate load case. A patient medically compromised, was on some medications that caused blood dyscrasias and difficulties in bleeding and maintenance, so we decided not to open large wounds on the palate, but we had significant mucogingival challenges around these implant abutments. We went ahead, and as you can see here, still sound principles of flap design. Obviously a large flap, not minimally invasive, but we're going to suture this down into the vestibule. We're going to do a split thickness dissection, supraperiosteal, create a blood-borne bed preparation to support this living tissue. And this living tissue then can be used and sutured into position and then avoid a secondary surgical site. Now you can take a look at this. This is only 3 weeks later, and this is at 6 months. Look at the vestibular depth that was attained, the restoration in place, and being able to be maintained with this type of tissue design. So here's a medically compromised patient where harvesting large zones of free gingival tissue may have complicated wound healing, may have been a risk for hemostasis and maintenance, and we were able to do it without. When you think about gingival wound healing, I think we still have to think biologically. And I think we have to consider that we need to establish and maintain a plasmatic circulation from the periphery of the wound, from our bed preparations, from maintaining the periosteum. And also we have to consider, to ensure ideal conditions for healing, the blood that pools up between the graft site and the bed preparation should be thin. So the excess blood should be removed by exerting gentle pressure against the graft following suturing. You want to minimize that fibrin layer. You don't want a very large amount of blood that has to be broken down by the body during wound healing. So all of these things lend themselves to a better result. So we have to think of flap design. We have to think of maintaining a proper bed preparation. Here's a patient with an ectopically erupted canine. He came to our office for a third opinion regarding whether or not the tooth should be extracted and an implant placed. This patient was 25 years old. The tooth was completely stable. No mobility, simply ectopically erupted outside the alveolus. So we have 10 millimeters or more of gingival recession, no bone on the labial. Can this tooth be maintained in the arch? Where will we gain the technique that can give us the vascularity? So we're going to combine techniques once again here. We're going to utilize the keratinized gingiva that is located distal to this canine, and we're going to create a lateral pedicle graft that we will rotate over this root. And you got to think about these techniques, whether they're teeth or whether they're implant sites. Being able to utilize a pedicle so that we have a vascular source that's maintained. It's not a free graft, it's an attached graft, and we're going to be able to split the flap in this area so that we can adequately rotate it, tension-free, over the exposed root. We're going to prepare and design that root, making sure that we remove the smear layer, and I'll talk to you about that in just a moment. We're then going to also utilize autogenous tissue, connective tissue grafts, so it's a combination of techniques, connective tissue from the palate as a free graft, plus a rotated flap, so we have two blood supplies that would be able to assist us in the wound healing. We see this at 8 days, and now we see it at 8 weeks. And now at 8 weeks compared to the pre-op, you can see very, very early result in this area, and then several months later. The canine has been maintained. We have dense keratinized tissue over the area. The distal area has regenerated because it was split thickness, so it granulated in with keratinized gingiva. And at 1 year, this tooth is maintained in the arch. What would happen, more than likely, even though we still have a little bit of recession here, is if the orthodontic phase was instituted and we were able to move the canine back over the alveolar ridge, more than likely, this tissue would creep down and we would gain further root coverage. But certainly now, this is about 5 years, and this patient still is doing quite well and maintaining this with just a connective tissue attachment. A few years back, there was a study that was published in IJPRD where they looked at this technique, and that's been around for so many years in terms of its efficacy around lower central incisors. It was a 5-year clinical study done by Angelis and his group, and they basically concluded that it was still a very, very predictable procedure that can attain adequate results when gingival thickness and keratinized tissue are needed, and that we should consider it. So I think we still have to consider lateral pedicle grafts as a very suitable procedure, and in many cases, it can be used on its own without additional forms of soft tissue. Maybe we use it just with fibrin. Maybe we use it just by itself. So how do we prepare the sites? People often talk about you have a root that has been exposed to the oral cavity for a period of time. You want to make sure that you remove the exposed outer area of the root, the area that was exposed to the oral cavity, remove the smear layer, make sure you have a clean surface. Sometimes we plane the roots. Some people suggest using little burrs to plane them. I like to use hand instrumentation. It's really up to you. We take down any significant convexities. We make sure we check the occlusion, that there's no fremitus, that there's no occlusal trauma, there's no mobility of the teeth. It's very critical, no matter what technique you use, whether it's microsurgical, minimally invasive, or conventional. There should be no trauma from occlusion and no mobility of the tooth. Root preparation and conditioning protocols. We've been using this for many years in periodontics. I still use tetracycline or minocycline or any of the tetracycline family of products. We mix it with a little bit of the lidocaine. We create a paste and we place it on there for 3 minutes. This concept provides us with quite a few things that I think are advantageous. It removes the smear layer entirely. It has an antimicrobial effect. It opens up the dentinal tubules, and it does promote fibroblast proliferation. Imagine today if we can use this in concert with some of the growth factors that are now available, it would lend itself to ideal wound healing. And some of the products that have been used in terms of mucogingival surgery, tetracycline, obviously EDTA, citric acid, and enamel matrix proteins. I still utilize this material. We went ahead, sutured it. This was original drawings from Bert Langer's work back in 1987, where Bert suggested that you can keep as much as 20% of the autogenous tissue exposed.